Good day, and thank you for your interest in the educational review, Chloroprocaine for Epidural Anesthesia in Infants and Children, published in Pediatric Anesthesia. This is Giorgio Veneziano from Nationwide Children's Hospital in Columbus, Ohio. I'm pleased to present to you information pertaining to the application of 2-chloroprocaine for continuous epidural anesthesia and analgesia in the pediatric population. Several studies in the early 1990s presented the use of continuous chloroprocaine epidural infusion as either the sole anesthetic or combined regional general anesthetic for neonates and preterm infants. These reports demonstrated effective intraoperative anesthesia and early extubation times without supplemental opioids or adverse effects. More recently, publications have examined continuous chloroprocaine epidural infusions for postoperative analgesia in infants after major abdominal and thoracic surgery. The majority of these studies are retrospective and observational in nature. They reported opiate consumption and pain scores that indicated chloroprocaine may be a suitable alternative to aminoamide local anesthetics. One study compared chloroprocaine and ropivacaine continuous epidural analgesia in infants after thoracotomy. The results indicated weak evidence for a reduction in opiate consumption with chloroprocaine compared to ropivacaine in the first postoperative 24 hours. To facilitate understanding of the utility of continuous chloroprocaine epidural anesthesia, reviewing some reflective questions may be helpful. Reflective question number 1. What are the clinical concerns regarding the use of amide local anesthetic agents in infants and children? Increased awareness of the consequences of uncontrolled pain in neonates and infants and the perceived risk of apnea with systemic anesthesia help popularize the use of neuroaxial anesthesia in this population. However, in the early 1990s, multiple incidences of local anesthetic systemic toxicity in infants receiving continuous bupivacaine epidural infusions were published. An investigation by the Anesthesia Patient Safety Foundation revealed that in all cases the dose of bupivacaine exceeded 0.5 milligrams per kilogram per hour. Recommendations were made to keep bupivacaine infusions at or below 0.2 milligrams per kilograms per hour in neonates. A subsequent study demonstrated that even at this recommended rate, bupivacaine continued to accumulate in plasma of neonates at 48 hours after initiation of the infusion. Ropivacaine at the same dose has been demonstrated to not accumulate. However, concern over local anesthetic systemic toxicity remains. Particularly at risk are infants with pre-existing hepatic impairment or surgery involving the liver. Due to the restrictive dosing limitations of aminoamide local anesthetics in infants, adequate coverage of incisions stretching multiple dermatomes may be difficult. Question number 2. What physiologic factors predispose infants and children to local anesthetic toxicity? Neonates and young infants have an immature microsomal P450 system, which results in prolonged metabolism of aminoamide local anesthetics such as bupivacaine and ropivacaine. The extended half-life leads to accumulation of drug in the plasma of young infants when infusion doses appropriate for older children or adults are used. In addition, lower levels of alpha-1 glycoprotein in neonates, which bind aminoamide local anesthetics, lead to higher percentage of free drug in the plasma. Question number 3. How do the pharmacokinetics of 2-chloroprocaine differ from ropivacaine and bupivacaine? Chloroprocaine is an amino ester local anesthetic with an ultra-short duration of action. The plasma half-life of chloroprocaine is seconds to minutes and has limited age-dependent changes. Metabolized by plasma cholinesterases, there is no involvement of hepatic microsomal enzymes for degradation, and the drug is not protein-bound in plasma, further eliminating age-related differences. These properties make chloroprocaine an attractive alternative to aminoamide local anesthetics used for regional anesthesia in infants. What clinical concerns have been expressed with the use of chloroprocaine for regional anesthesia? Neuroaxial use of 2-chloroprocaine was associated with several cases of cauda equina syndrome in the 1980s. Most of these cases involved inadvertent intrathecal injection of large doses of chloroprocaine containing the preservative sodium bisulfite. While controversy remains, sodium bisulfite has been found to be a potent neurotoxin and may explain these cases of neurological injury. Subsequent neuroaxial use of chloroprocaine has focused on the preservative-free formulation. Studies examining neuroaxial anesthesia with chloroprocaine following the removal of the preservative have been reassuring. The rare individual with atypical plasmacholinesterase presents a dilemma for the use of chloroprocaine as a regional anesthetic. Seizures and high epidural block have been reported with neuroaxial use of chloroprocaine in such individuals. Chloroprocaine is best avoided in patients with a known personal or family history of atypical or deficient plasmacholinesterase. Adverse effects reported with the epidural use of chloroprocaine in children include bradycardia, hypotension, and pruritus. However, in nearly all cases, the authors of these reports called these adverse effects mild, transient, or unrelated to the epidural infusion. Another concern with continuous chloroprocaine epidural infusions in infants is the potential for increase in leakage of local anesthetic solution from the catheter insertion site. The larger infusion rates of chloroprocaine compared to aminoamide local anesthetic make leakage more probable and may increase the potential for addressing dehiscence and inadvertent catheter removal. Question number 5. What has been the clinical experience with local anesthetic systemic toxicity related to chloroprocaine in infants and children? There are only 2 published reports of local anesthetic toxicity with chloroprocaine in children. One case involves a 2-month-old with an epidural catheter inserted through the sacral hiatus. After an initial bolus of 1 ml per kilo of 3% chloroprocaine, the patient experienced a 30-second period of white complex bradycardia. The catheter in this case was radiographically confirmed to be intravascular. The other case was a 9-month-old with bilateral perivertebral catheters placed for postoperative analgesia that convulsed for 40 seconds after an approximately 1 ml per kilo bolus of 3% chloroprocaine was administered via the catheters. In both of these cases, signs of local anesthetic toxicity resolved spontaneously before further intervention could be instituted, and there were no further sequelae. In conclusion, the potential advantages of continuous epidural infusions with 2-chloroprocaine, including metabolism independent of the microsomal enzymes, a limited age-dependent half-life, and higher infusion rates allowing expanded epidural spread, make it an attractive alternative to aminoamide local anesthetics in infants. In the future, prospective studies will help elucidate the true efficacy and safety of regional anesthesia with chloroprocaine in this unique population.